The topic of this presentation is neural tumors. We'll be discussing optic nerve glioma, optic nerve sheath meningioma, and plexiform and isolated neurofibroma. Starting with optic nerve glioma. Optic nerve glioma is a slowly growing pilocytic astrocytoma that typically affects children with a median age of 6.5 years. Histopathology shows spindle-shaped pilocytic astrocytes and glial filaments. The prognosis is unpredictable. Some have an indolent course with little growth, while others may extend intracranially and threaten life. Approximately 30% of patients have associated neurofibromatosis type 1, and in these patients, the prognosis is superior. Malignant glioma or glioblastoma is rare, has a very poor prognosis, and usually occurs in adult males. Diagnosis is based on symptoms, signs, and investigations. Symptoms include slowly progressive visual loss, followed later by proptosis, although this sequence may occasionally be reversed. Acute loss of vision due to hemorrhage into the tumor can occur, but is uncommon. Signs are proptosis, which is often non-axial with temporal or inferior dystopia, as it is shown in first picture. The dystopia is temporal and inferior. The optic nerve head is initially swollen but subsequently becomes atrophic. The white atrophic disc is also shown in the figure here, and you can see it here in this picture. Opticociliary collaterals and other fundus signs such as central retinal vein occlusions are occasionally seen. Intracranial spread through chiasm and hypothalamus may develop as well. On investigations, we do imaging. MRI effectively demonstrates tumor and may show intracranial extension if present. Here the MRI is showing this extension of the nerve on the right side. CT in patients with associated neurofibromatosis. Show a fusiform enlargement of the optic nerve with the clear-cut margins produced by intact dural sheath. In patients without neurofibromatosis, the nerve is more irregular and show low-density areas. The axial MRI here is also showing kind of a fusiform enlargement, so we might presume that it is also associated with neurofibromatosis. As the tumor is intrinsic to the optic nerve, resection means that all the vision will be lost in the operated eye, so observation may be considered in patients with typical pilocytic astrocytoma on imaging in whom the tumor is confined to the orbit, especially if there is good vision and no significant cosmetic impairment. Serial MRI is important. If this option is chosen, spontaneous regression has been reported, usually in neurofibromatosis type 1, but this is very rare. Then comes surgical excision with preservation of the globe. Is indicated in those with large or growing tumors where complete resection of the tumor can be achieved. Particularly if the vision is poor and proptosis is significant, a key goal is to prevent chiasmal involvement, and an intracranial approach may be necessary to achieve adequate resection. Radiotherapy may be combined with chemotherapy for tumors with extension that precludes complete surgical excision. The next tumor is optic nerve sheath meningioma. It is a benign tumor arising from meningothelial cells of the arachnoid villi surrounding the intraorbital, or less commonly the intracanaliculair portion of the optic nerve. In some cases, the tumor merely encircles the optic nerve, whilst in others it invades the nerve, growing along the fibrovascular pile septa. However, 2/3 of all meningiomas affecting the optic nerve arise from extension of primarily intracranial lesions. Primary optic nerve sheath meningiomas are less common than optic nerve gliomas, and as with the other meningiomas, typically affect middle-aged women. Histopathologically, meningothelial, which are irregular lobules of meningous meningothelial cells separated by fibrovascular strands, and semomatous uh, types are distinguished, which contain semoma bodies among proliferating meningothelial cells. Uh, the prognosis for life is good in adults, although the tumor may be more aggressive in children, in whom 25% occur. They are more common in neurofibromatosis type 2 as opposed to optic nerve glioma. So the histological slide on the top shows meningothelial, and on the bottom it shows semomatous type. Now, diagnosis is based on symptoms, signs, and investigations. Symptoms typically consist of gradual visual impairment in one eye. Transient obscuration of vision may occur. The classic Hoyt-Spencer triad consists of progressive visual loss, optic atrophy, and opticociliary shunt vessels. Although the simultaneous occurrence of all three signs in one individual is actually uncommon, the usual sequence of involvement is the opposite of that seen in tumors that develop outside the bural sheath. Optic nerve dysfunction and chronic disc swelling followed by atrophy. Opticociliary collaterals 30%, which regress as optic atrophy supervenes. Restrictive motility defects, and then proptosis. The motility defect is also seen in the picture on the top. You can see that there is defective elevation on the right side. Proptosis is on the picture on the second picture. Now, investigations on the CT scan shows thickening and calcification of the optic nerve, which is shown here on the right side. You can see that the optic nerve is thickened, but also there is also calcification here. Axial MRI shows a lesion associated with left optic nerve here, and we can also use ultrasonography, especially coronal. Now, treatment may not be indicated in a middle-aged patient with a slowly progressive lesion, but excision is required for an aggressive tumor, particularly if the eye is blind and there is a risk of intracranial extension. Attempts at optic nerve sparing surgery commonly fail but may be considered on a case basis. Fractionated stereotactic radiotherapy may be appropriate as a vision sparing approach or as adjunctive treatment following surgery. Now, the next tumor is plexiform neurofibroma, which is the most common peripheral neural tumor of the orbit. It occurs almost exclusively in association with neurofibromatosis type 1. Presentation is in early childhood with periorbital swelling. Classically, involvement of the eyelids causes mechanical ptosis with a characteristic S-shaped deformity, but diffuse involvement of the orbit with disfiguring hypertrophy of periocular tissue may occur. On palpation, the involved tissues are said to resemble a bag of worms. Malignant change can occur and should be suspected if there is a rapid change. Radiotherapy may promote this. Treatment is often unsatisfactory and complete surgical removal is extremely difficult. Orbital surgery should be avoided when possible because of intricate relationship between the tumor and the important structures. Then is the isolated neurofibroma, which is localized neurofibroma. It is less common than the plexiform neurofibroma. In about 10% of patients have neurofibromatosis type 1. Presentation is in the third or fourth decade with insidious and mildly painful proptosis, usually not associated with a visual impairment or ocular motility dysfunction. Excision is commonly straightforward because the tumor is well circumscribed and relatively avascular. So that's it with the neural tumors of the orbit. If you like the lecture, please press on the like button and subscribe to the channel. Thank you very much.